The bowel wall doesn't lie. Let's learn some RadPath of the small bowel. So if you've been following my podcast or I got in the book, don't miss that radiology. You know I'm a big fan of loud burps and farts. Air rises, so it's important to know how the study was taken. Was it upright or supine? Because free air and obstruction will look differently. The rule of threes. 3 air fluid levels or more is abnormal. Realize we'll only see this if the patient is upright. The small bowel diameter should be less than 3 centimeters, and the wall thickness should be less than 3 millimeters. We got to know the normal patterns, appearance, histology of the bowel. The name of the game for the bowel is water absorption and nutrient absorption. So we want as much surface area as possible to absorb the nutrients. So jejunum has lots of folds, ileum not as much, but if you remember, much of our immune system, I think it's like 50%, is located in our bowel, and we'll get these little Peyer's patches. So what does the bowel look like? Well, it depends which modality you're doing. Back in the olden days when I was a resident, we did lots of fluoro, and a great way to look at the small bowel. And you got your stomach there, duodenum crosses the left midline, crosses the ligament of Treitz, and we'll have our jejunum and ileum. And just note those thickened folds for the jejunum and not as much for the ileum. If you have a reversal of that pattern, that's something you can see with sprue. So keep that in mind. And we'll look at some great Netter pictures. So our folds, again, surface absorption. Got the villi, the microvilli, and again, just maximizing absorption. So the rule of threes for the bowel, diameter should be less than 3 centimeters. Fold thickness, less than 3 millimeters. Wall thickness, less than 3 millimeters. And our fluid levels, if we have any, should be about the same height. And anytime you have an abnormality with the small bowel, always consider 2 things. You never go wrong. I know I usually say Metz lymphoma for all differentials, but if we have the small bowel, we'll also add Crohn's, especially if it's in the terminal ileum. But we also have lymphoma. Lymphoma, the small bowel, is not uncommon. And we're going to really focus on that with our RadPath. So lymphoma radiology, 4 ways it can affect the small bowel. You can have a solitary mass or polyp. You can have thickened folds, multiple masses, or aneurysmal dilation. So thickening in the terminal ileum. So we said that this is going to be the key area. And again, we got lymphoma and Crohn's in our differential. So our neoplastic causes are going to be lymphoma and carcinoid, and our inflammatory causes, Crohn's, nephritis, and TB. Now this is a gross specimen from the distal ileum. It's dilated, and we're also going to see it's thickened when we open it up. This is aneurysmal dilatation of the small bowel. This is a great differential to know. And we can see it with lymphoma, carcinoma. Now realize carcinoma of the small bowel is rare. Usually it affects the duodenum if it's going to affect the small bowel at all. Leiomyosarcoma or GIST tumor. And then Mets to the bowel wall. Now it's interesting, for as much surface area, as much volume as there is for the small bowel, pathology to the small bowel is relatively rare compared to colon cancer, compared to the colon, much higher rate of colon cancer. So let's look at this example of aneurysmal dilatation on CT. So the whole diameter is dilated. If you remember the Hartman 6 patterns, if not, go back to that intro video for RadPath, but the whole small bowel is dilated, and then this is the lumen inside, so the wall is thickened. So we have thickening with dilation, that's aneurysmal dilatation, and we have our differential lymphoma is going to be number 1 for it. So what else can lymphoma look like? Well, we can have multiple masses or innies in the small bowel. We realize some are smaller than others, but we have multiple. Anytime you have multiple, think lymphoma or Mets. This is a case of lymphoma. And here is a great gross specimen just showing these thickened folds. In some places it's nodular, but again, lymphoma for the small bowel. Let's go to another case. This is a small bowel follow-through. And what do we have? Well, it looks like an area where contrast is not opacifying the small bowel. That's a great look for a innie. And what could this innie be? It looks sort of like a coiled spring. There's our nice overlay. And this is a Ant Mini for intussusception. We're going to have a great gross specimen of this, but basically in a kid, you can see this idiopathically. Sometimes it can cause obstruction. If you remember our causes of small bowel obstruction, intussusception is one of them, especially if there's current jelly stool in the kid. That's what you're thinking. In older adults, you're thinking lead points. Is there a polyp? Is there a tumor? Is there a lipoma sort of thing? But this is an example of intussusception. And let's look at the gross specimen where you have telescoping of the bowel of the intussusceptum into the intussusceptions, which sort of receives it. And we talked about in kids, it's often idiopathic, but in adults, you worry about polyp, lymphoma, and then sprue, other things. Meckel's diverticulum, which we'll talk about, can also cause intussusception. This is a really fun case of an innie, if you've never seen this before, but it looks like we got some normal bowel there, and then here we have all these filling defects, but within the filling defects, we got a thin line of contrast, almost like something ate the contrast. And that's exactly what we're seeing. These are going to have a differential, so multiple filling defects. Yeah, Metz lymphoma. But if you ever see this appearance, this is a roundworm. And let's see the gross picture. You can just imagine these roundworms in the small bowel, which are eating, trying to digest the barium, and the barium's going through. So you get the roundworms, which are sort of round or tubular, and you get that band or thin ribbon of contrast within their GI tract. So anytime you have multiple masses or innies in the bowel, yeah, that's lymphoma, every differential. And then rarely polyposis syndromes, Kaposi's, carcinoid, and then roundworms. So let's just see another example of multiple innies. Hopefully your short-term memory says, hey, that looks sort of familiar. Multiple innies, hey, Metz lymphoma. Yeah, that was our case of lymphoma. Again, hopefully you can imagine these filling defects projecting into the lumen there, causing those filling defects. So it's important to know the histology for the small bowel, villi, folds, and realize, just like the lung, we said 4 things can go in the lung that make them extra white: blood, water, cells, pus. 3 things can go into the folds or villi to make them thickened. And we're going to have fluid, blood, and cells. I guess technically you can have pus as well. We'll sort of put that with cells with like an enteritis. But we'll make this one a little bit easier. We have 3 things that can go in: fluid, blood, or cells. But again, only so many ways the body can be affected by pathology. We had our 6 patterns, and you just remember these general categories: blood, water, cells, or pus. That's usually what's happening. So what's happening here? Here's a small bowel follow-through. These folds are thickened. Yeah, blood, water, or cells. And this patient was being anticoagulated, and this is hemorrhage into the wall of the small bowel. This is called the stacked coin sign. Again, the finding itself is nonspecific. You have to correlate with the rest of the history, the picture, to get the diagnosis. Okay, what do we have here? I have an outpouching off of the small bowel. What could this be? Well, it's nice we have the number 2 because we're going to talk about the rule of 2s for this pathology. You're probably saying, Meckel's diverticulum. Well, you're right. This is one of the practical embryology things we got to know or remember. This is persistence of the omphallomesenteric duct. And if it persists, you will have a true diverticulum, meaning it has all the layers of the bowel. It's going on the antimesenteric side. 25% will have gastric mucosa, which we can use to our advantage and diagnose it with a technetium scan. Most of the time it's asymptomatic, but sometimes we talked about the complications of intussusception, bleeding, or obstruction. So the rule of twos. So 2% of the population, 2 times more common than males. It's usually within 2 feet of the ileocecal valve, 2 inches long, and it can contain 2 types of ectopic mucosa, gastric. So I've seen ranging percentages for that, but it can also have pancreatic tissue, which is less common, only symptomatic 2% of the time in adults. But if it's going to be symptomatic, usually before 2 years of age with some bleeding in the pediatric infant. So here's a great companion case from Dr. Daphner. So we'll start with the scout, stones, bones, mass, and gas, and we'll see the kidneys are excreting contrast in the bladder, but we get these sort of bright things in the right lower quadrant. What could they be? Let's do a small bowel follow-through. We get this outpouching off of the small bowel filled with a bunch of innies. What could these innies be? Well, we talked about mets, polyps. It's weird that they're only in this diverticulum. Maybe something's accumulating in there. And that's exactly what the case was. These are watermelon seeds, which are got in but can't get out. So that is our Meckel's diverticulum. Okay, let's do a couple more ant minis. This is a bone marrow patient with abdominal pain. We do a small bowel follow through. And where are the bowel folds? I'm not seeing it. They're effaced. And hey, this sort of looks like toothpaste. Yeah, you're right. This is a toothpaste sign, and this goes with graft versus host disease. And you see this in marrow transplant patients who are immunocompromised. Okay, how about this small bowel follow through? Well, the lumen is markedly narrowed in the terminal ileum. We said every differential for small bowel pathology, lymphoma, and Crohn's. We haven't seen any Crohn's yet. So that's what this is. This is the string sign. And you just got to imagine there's all this fibrosis and thickening around the lumen, or through the wall of the lumen, causing the lumen to be narrowed. So that is our string sign. You can read about that. Here's another small bowel follow through, again on the terminal ileum, so thinking Crohn's. And here's our lumen, and we have extraluminal contrast. We're making a second track. Double track sign. This can go with Crohn's, can go with diverticulitis, especially in the colon. But this is a case of Crohn's disease where you have an ulcer going outside the normal lumen. So Crohn's, diverticulitis, and carcinoma. And another patient with Crohn's, so small bowel follow through. We haven't seen anything like this, no folds, but instead we're seeing all these innies. You might say, hey, those could be polyps. Yeah, that's a good thought. But in this patient with known Crohn's disease, this is cobblestoning. This would be a real bumpy road if you're trying to drive on that. And what you're seeing is the normal versus abnormal mucosa, or with the intervening ulcerations. And we'll end with one fun case. This is for any R1s. This is a great one while you're getting your search patterns for a trauma patient. No free air, no free fluid. But the interesting thing, when you try to track the stomach and duodenum, instead of crossing the ligament of Treitz, all the small bowel stays to the right of midline. And we'll note our aorta, SMA, normally the duodenum crosses between there. But interestingly, our SMA, SMV are stacked on top of each other. Usually the SMV is a little bit more the right of midline. So I know you guys are all thinking, hey, maybe this is malrotation. That's a really good thought. So there's our SMA, SMV relationship. And we will confirm it with our small bowel follow-through. Again, the duodenum should cross to the left of midline, and instead all the all the small bowel stays to the right. The colon will be on the left. Why is this important? Well, if you a newborn with bilious vomiting, day 1 of life, you're absolutely thinking malabsorption, but not all. You're thinking malrotation, but not all patients with malrotation will present like that. Some, depending on how tight the lap bands are, can go live a long life, never knowing that their bowel's on the wrong side. And it's unless they get some imaging, or probably would be none the wiser. Now, why is this important? Well, where's the appendix going to be? It's probably going to be on the left side. So if a patient presents with left-sided pain, you might be thinking diverticulitis, but in fact, it's really appendicitis. So if you are seeing that malrotation, be aware of that, make note of it, but as long as they're not obstructed, it's probably just an incidental finding. So that was a lot of small bowel pathology. We certainly didn't cover everything, but if you remember the main things, every differential for the small bowel pathology, lymphoma and Crohn's. Remember how lymphoma can present multiple masses, aneurysmal dilatation, single mass, and diffuse thickening. And we had a couple of fun ant minis.